Hello, my name is Yurie Kawabata, and I am a gastroenterology fellow at the Digestive Disease Center of Showa Medical University, Northern Yokohama Hospital in Japan. Thank you very much to Gastrointestinal Endoscopy for this opportunity to share our work as part of the author interview series. It is our great pleasure to introduce our recently published article entitled Clinical Impact of a Combination of Lesion-Border Findings and PIT Patterns for Identifying Invasive versus Non-Invasive Neoplastic Lesions in ulcerative colitis. Patients with long-standing UC are known to have an increased risk of developing colorectal cancer compared to the general population. Traditionally, total colectomy was considered the standard treatment for UC-associated neoplasia. However, after the cynic statement, endoscopic resection and surveillance colonoscopy have become more accepted as alternatives. Cynic also introduced a novel concept, lesion-border findings, as part of the recommended terminology in surveillance colonoscopy for IBD. However, these border features have remained poorly defined, and no standardized method of evaluation has yet been established. Additionally, ESD has been reported as a useful technique because it allows en bloc resection of larger or deeper lesions. But ESD requires a high level of technical expertise and should only be performed in specialized centers. On the other hand, EMR is more widely accessible, but it often results in piecemeal resection, which may compromise accurate histological evaluation, especially in cases with possible submucosal invasion. This can complicate treatment planning and may even result in adverse outcomes. Therefore, it is essential to preoperatively differentiate between intermucosal and invasive submucosal lesions as accurately as possible. In clinical practice, Kudo's PIT pattern is commonly used to evaluate invasion depth in colorectal neoplasia. However, in UC patients, this method is less reliable. UC-associated neoplasia often coexist with inflammation, and many lesions exhibit a so-called bottom-up growth pattern, which makes surface-based evaluation more difficult. So, inspired by diagnostic strategies used in early gastric cancer, we investigated whether lesion border findings could help identify lesions where PIT pattern diagnosis is more or less reliable. To our knowledge, this is the first study to demonstrate the clinical impact of combining lesion border findings with PIT pattern classification to differentiate invasive versus non-invasive neoplastic lesions in UC. In this study, we clearly defined how to evaluate lesion borders. After indigo carmine spraying without magnification, we classified the borders as either distinct or indistinct. Border distinct lesion had a clear circumferential step. All others were categorized as border indistinct. We also evaluated inter-observer and inter-observer agreement for these definitions. Both were high, even among non-expert endoscopists, which suggests that the lesion border evaluation could be standardized in future practice. Our results shows that when lesion had a distinct border and a type 2 or 3 LPIT pattern, they were all intermucosal. In contrast, when the border was indistinct, and even lesions with a non-invasive PIT pattern sometimes showed submucosal invasion. We found that the sensitivity, accuracy, and the positive predictive value of PIT pattern diagnosis were significantly higher in lesions with a distinct border compared to those with undistinct borders. These findings suggest that lesion border assessment can serve as a helpful adjunct when interpreting PID patterns and may help predict which cases are suitable for endoscopic resection. Based on our findings, we propose the following approach. Endoscopic resection should be considered for border distinct lesions with a type 2 or 3 LPID pattern. For all lesions, more cautious evaluation is needed before deciding on the treatment approach, rather than proceeding directly to resection. This study had several limitations. It was a retrospective single-center pilot study conducted at a referral center, and the sample size were relatively small. To address these limitations, we are currently planning a prospective multi-center study with a larger sample size to validate the clinical utility of lesion-border findings in guiding endoscopic resection strategies in UC. Once again, I would like to thank gastrointestinal endoscopy for the opportunity to present our research. We hope that our findings will be helpful for clinicians performing endoscopic evaluations in patients with UC. Thank you very much for watching.